Good afternoon and welcome to the Health Overview and Scrutiny panel. I'm Councillor Leonie Oliver and I'm the lucky chair of the panel for today. So housekeeping: if a continuous fire alarm sounds, please evacuate the room and public gallery by the stairwells. Do not attempt to use the lifts and please assembly at Queen Victoria statue. In order to comply with the Guildhall's Trust Fire Marshal regulations, anyone who has signed in at the Guildhall reception desk should sign out when leaving the building at the end of today's meeting. May I draw your attention to the fact that this meeting will be live streamed, and everyone speaking, please do so via the microphone. Members of the press and public are also permitted to record the meeting on the understanding that neither disrupts the meeting nor records those stating explicitly that they do not wish to be recorded. Please can everyone use the microphones and remember to switch them off when they are finished. I'd like to welcome new members to the panel, and we will go with introductions, please. From my right, go from my right.
Lisa Gallagher from Democratic Services.
Hello, I'm Councillor Mark Jeffrey, St Thomas Ward in Portsmouth.
Councillor Susie Horton, Central Southsea Ward.
Good afternoon, Chair. Councillor Matthew Cordy, Hilsey Ward.
Hello everyone, I'm Councillor Charlene Mains and I'm from East Hampshire District Council representing Rowlands Castle Ward.
Afternoon, Councillor Michael Bennett from Winchester City Council. I'm Denmead Ward.
Judith Smythe, St Jude Ward, Southsea.
So I'm Gillian Harris, Councillor at Havant Borough Council. Thank you.
Microphone. Members have read the report, so presenters, please just highlight any developments that have occurred since the publications. We've got apologies from Councillor Minahan, and at the moment Siobhan isn't here, so we're going to do a bit of a juggle around when we get on to that. Can I ask if anyone has any declarations of interest? Perfect. We'll go on to agenda item 3, minutes of the previous meeting. Has everyone gone through the minutes, and if any members need any corrections? If all's fine, I need a proposer and a seconder. You weren't here, that's correct.
I'm happy to propose.
You weren't here, and I'll second, that's fine. Perfect, so agenda item 4 was Siobhan, but we're going to jump ahead to 5. That's okay. Bernie. James. It's not Bernie.
I'm Director of Primary Care and Local Care, so I'll speak to the item. So you've got the report. Just a few things to update on since the last meeting. We reflect the growth in GP appointments. We've had July data, and July data is 24,000 more GP appointments this July versus last July. And across Hampshire and the Isle of Wight, there's 1 million appointments, over 1 million appointments. So as you all know, general practice is busy, as is the hospital. The whole system is busy at the moment and all doing what they can to manage that demand. The other thing reflected in the report is pharmacy first. And again, this committee will know we've done a lot in terms of developing community pharmacy to provide more services and as an alternative to general practice. July figures shows we've got the highest number of clinical consultations in the region. And just to break that down a bit, one example is oral contraceptives being available in community pharmacy. Across Hampshire and the Isle of Wight, we had about 2,500 consultations of that type, and quite a high number in Portsmouth. So I think it really shows the variety of service provision within primary care. You'll note the detail in relation to the patient survey in the pack. The issue with the patient survey is it's often annual, so you get an annual view of experience. By the time you get the data, the ability to proactively act on that is limited. What we have started to do now is use ONS data on a monthly basis, and that tests two things. One, the ease of access for someone into a GP practice. The other thing it tests is whether that individual has a preferred healthcare professional and an appointment with that preferred healthcare professional as well. So you'll see annual survey in the report. We track that monthly, And what we're trying to do through this committee is give you an in-year position so you can see how that changes. Two other things which I think are relevant since the paper. One is that, and I'm sure you'll be aware, the dental school has now got approval from the Privy Council. So that's great news in terms of getting more local dentists in Portsmouth. And so sort of congratulate Chris Luca for that and everyone for their support. We recently closed off our dental access figures for 24-25. And overall, we saw an 11% increase in dental appointments this year versus last year. The highest growth was in Portsmouth at 10%. So clearly some of the additional work around procurement is helping. You'll also be aware of the mobile dental unit as well, which is having an impact. So, and then the last point, hopefully you're aware that Portsmouth has been chosen as a national demonstrator site for neighbourhood health. And I think there was a press release this week. So clearly key priority for us to support that, build on the good foundations. And I'm sure when we take the item later with the hospital, there's a lot more we can do at the interface of primary and secondary care, particularly in terms of case management and admission avoidance. So that's the paper, Chair, and they're the substantive updates since the paper was published.
Thank you very much. Over to the floor for any questions. Mark.
Yeah, thank you. What would you say is the reason for the 7% increase last year? Is it to do with literally demand, or is it also being led by more appointments being available? You see what I'm saying?
So demand is clearly a driver. I think what we're pleased with is that we're able to provide more same-day appointments. So we've invested in the same-day access programme. The other thing I'm really pleased about is the variety. If you look at the split of that growth across a healthcare professional within general practice, you will rightly see the high proportion being GP-led, but encouragingly there's a lot more that are nurse-led, pharmacist-led, redirected into another route. So that's positive. I think the other thing perhaps you need to be aware of is from October, we're extending online appointments from 8 a.m. in the morning to 5:30 in the evening, Monday to Friday. So I think that will be a game changer in terms of how people access general practice as well.
Perfect. Have you got a follow-up, Mark? No? You're okay? Judith.
I've got two questions, not quite related. The first is the GP patient survey. Is that a separate questionnaire, or when I go to the GP at all, which I do infrequently, there's always a immediate response with a questionnaire to fill in straight away for the GP. Does that get fed through to your survey as well?
So the survey referred to in the report is a national survey, so every GP practice forms part of that. Whatever the practice do, local level will feed their feedback. Obviously, every practice has got a patient participation group. We want to track experience beyond the annual survey, if you like. So that sort of stuff would feed the conversations we have with the PPGs around experience and insight as well. And that's why we use monthly indicators like the ONS survey, just to see trends and issues.
I think the ONS survey and other things are really, that's very interesting. But so when I went this morning actually for something very routine and relatively not life-threatening or anything. I've got the survey to fill in. If I fill that in, will that feed into this directly? You didn't quite make clear what that was.
No, this comes out at a set point in the year, so I'm quite happy to come back with you in terms of the flow of that and what it means. Okay, no, that's clear. Thank you. The second thing is on my way to the GP this morning, I met a neighbour, and we both agreed that we'd had very easy to get appointments, everything like that. But we thought that the public relations were still terrible. And I'd also read this paper and seen that really the trends are going in the right way. In most cases, there are a couple that are going down a fraction of a percentage. But how can the NHS locally and the government actually get the message out to people that things are improving? Because he and I walked a quarter of a mile together talking about how many people we knew who still just complain and complain and complain, when actually both he and I were on our way to appointments that we've managed to arrange and take up within 8 days, which I think is, for something non-life-threatening, is perfectly acceptable. How do we improve the message out there? So
I find myself quite often as a councillor defending public services, as I'm sure we all do. And, the amount of cynicism and despondency and depression and ignorance out there is extraordinary.
Yeah, I think the last year, what we've tried to do through the It Takes a Team engagement campaign, which started in Portsmouth, is start to really set people's expectations around what services they can get in primary care and general practice. So clearly, primary care is more than the GP. And I think that's been really helpful in terms of helping to educate people around what they can expect. And actually, if you do have an appointment with a nurse or a pharmacist, it's not less of an appointment or less important. It's the right appointment at that point in time. So we've done a lot on that, and we've had good feedback on that. With the extension of online appointments from October, there's going to be a national document called the Patient Charter, and that will very clearly outline patient expectations, also the patient's own responsibility in terms of getting ready for an appointment and using things like the NHS app. What we're going to do as well off the back of that is remind people of the various ways in which they can access an appointment. And just one more point on the NHS app, we're currently 65% use across Hampshire and the Isle of Wight, which is a big move from where it was 12 months ago. Still a lot to do, but thankfully more people are using the NHS app now. And if you think about the number of repeat prescriptions ordered through the app, we're in the millions. So slowly we're getting there, but I think we have to keep putting the message out in terms of range of appointment, expectation, and sort of trying to manage that. And I think, again, through these committees and through your working communities, I think we can do that together.
If I can ask us, I mean, I think that sounds fine, that's great, but it's not what I hear when I'm walking around the streets to canvass and other things. And I also think that the NHS app, the app that we use at the moment is extremely clunky, and I know lots of people who give up. And the people who actually get appointments are those that walk around the corner and make an appointment at the desk. I think there's a very long way to go, and I think there's some national messaging must come out soon to prevent this cynicism continuing. And there are some people who will never be able to use that degree of, was with a neighbour who doesn't even understand about having a PIN for his bank account. He's not going to use the app. He doesn't understand anything about it. And there are still a significant number of people who either need help, and it's difficult to get help when you haven't got the... it's all right to do it yourself because you've got a number, you've got recognition, you've got face recognition, but you can't get anybody else's face recognised. It's very difficult. I would say you've got, 20% of people who are continuing to do the efforts the NHS are making a damage in their communities every day by not reporting correctly and being endlessly cynical and negative about things. And I'd say you've got 20% who will never find it easy to use the apps and things. I know it's always been a problem, but I think it's particularly a problem at the moment because there are clearly big efforts being made, and we've got the proof of it here.
All good?
Yeah, yes, I'd like to see, some more results about outreach and how it's actually done. I think most people I know are not aware of what you can do at a pharmacy. Most people don't read it up like I do. I've been always interested in the health service and indeed run parts of it. But there's a tremendous amount of cynicism about it. And I'd just like some sort of, I'd like some report about reach. Because I think that without that, all your efforts and investment in the community neighbourhood medicine won't actually work, and people will end up even more confused. I'm sorry to be pessimistic. I'm normally an optimist.
No, happy to do that. I just think in the report, if you look at overall experience of general practice at 68%,
yes.
You look at overall experience of pharmacy at 89%,
yes.
The message is when you use it, and you use it properly, you get a good experience. So we've just got to keep pushing that message through.
Exactly. But
that
I'm
changes
about
behaviour
people
then.
who give up at the first hurdle, because
Yeah.
sometimes the first hurdle seems impossible.
Mark?
Yeah, it's great seeing these figures after the years, that you've had to come here and not necessarily be criticised, but we've been asking sort of questions, and I'm really pleased with the work, particularly around dentistry. The council stepped in, and the university and the local health services. The increases there are really good. Do you happen to know off the top of your head how? And it's probably a bit micro, I suppose, really, but how long the DentAid charity bus service is contracted for? Because it's used in my ward, and I know it's valued.
Yeah, so I'm pleased to say that we're seeking to recommission, so we're just currently going through a process by which we can do that. DentAid have been extended in the short term and we're just looking at how we can get Dentaid onto a standard NHS contract and provide more certainty in terms of service provision. So it's not a case of if, it's when, and it's making sure we wrap the right sort of contract around it. The Dentaid bus has done some fantastic stuff, not just in terms of access, but actually getting people to stay on the dental pathway and standardise, and that's the win, I think.
So the follow-up, I guess, to that is the service that will be contracted going to be more comprehensive or better? It's not going to be cut.
No, we need to build, because the inequalities are still there, and nationally there's a big push on urgent dental appointments, and I would argue most of the people that present at the mobile dental unit have a long-standing urgent need. So we are engaging with NHS England about making sure that the numbers and the data from the mobile dental unit contribute to our overall access figure, because we're the only ICB in the country that's doing it. There isn't currently a mechanism by which that data can be included, so local MPs are helping us push that through to the Minister to get that addressed.
Susie? And we'll come over.
Got a couple of questions. Back on the patient survey, that's a phenomenal response rate, I think 27%. But I'm curious as to, I mean, in terms of research, that's a really good response rate. I'm curious to know who got it, because if it's not linked to what Councillor Smythe was saying, which is the general survey, who gets that survey? That's a very specific number of people. I might have missed it, and in which case I apologise if it's elsewhere.
Yeah, I think there's been a few questions on the survey and the background to it. It's a sample of registered patients in each area. I'm happy as a follow-up chair just to provide a breakdown of how it's calculated, what the sample size is, and how we get access to that. But it is a sample.
Okay.
But yeah, reasonable response rate. But I think if we can start using things like ONS more and engage with our public differently, then I think we should get more routine feedback. And I think, as the councillor said, a lot of this feedback is happening day to day. It's just not captured.
Yeah, yeah. And that sort of links to my second question, which is I'm interested in how, and it again links with something, same ballpark as what Councillor Smythe was saying, is the experience of people who are digitally able versus those who aren't. Because I'm very curious about that, because it's very interesting actually. I changed surgeries, and what I now realise is I changed from the worst to the best. But actually, on a personal level, I can say that was true. I was absolutely staggered that I could get appointments, but I am digitally able, despite what some of my colleagues might think. And actually, if it wasn't for that, I'm not too sure whether I would be able to access the services as well. So I'm just a bit curious as to, I mean, great story, and actually I think all of us are saying anecdotally that it feels right, but I'm just interested in the demographics, because in 20 years' time, you're going to have people who are all digitally able, but in the meantime, we have a group of people who maybe aren't.
Yeah, I think it is often perceived to be age-driven, but actually, I think if you look at certain parts of Hampshire or Hampshire Nullarbor as a whole, some areas where you'd expect it to be quite low in terms of uptake is quite high. I think if you look at 65% regular use of the NHS app, and you start to break that down in terms of proportion of age groups in the population, proportion of age groups in good health, I would suggest a fair proportion of the 35% are probably those that are ill, immobile, living within a particular setting. So we're going to start to test it just to see what the range is. We've also got to make it easier beyond the app for people to access appointments. So the feedback we get often is, I'm using the app, I've asked for X, I can't get Y. The step change from October will be, you can access the app and you've got an opportunity to book online appointments 10.5 hours a day, Monday to Friday. So that's the step change. I think previously we've had people using the app and then getting slightly frustrated because they can't get that appointment that day, or they can't get the call back, or they're not clear on the follow-up. So the test for us over the next 6 months is go through the app, book your appointment online. We've then got to make sure we provide the service beyond it so people have the confidence to continue. But we will look to break that down again for the committee if it's helpful.
Yeah, definitely, that would be. Charlene.
Hi, it's not a question. I just actually, I'm new to the panel, and I just wanted to share a bit about me and just, to thank the NHS. I've got 3 health conditions, type 2 diabetes, sleep apnea and Marfan syndrome. I'm at both Portsmouth and Southampton. The story that I want to share quickly is my type 2 diabetes. Now, I went to my GP, 41, was having symptoms that felt like perimenopause, and actually he took the blood test and it turned out to be the diabetes. I've been supported. The NHS app has really helped me with medications and appointments, and I do feel there needs to be more reach, especially with the younger generation as well, maybe in schools, because actually I went for contraception, and I've done my bit for the population, but it was actually the pharmacy that prescribed me with the pill, sorry, not the morning after pill, the pill. And at first I was a little bit dubious with it because I was thinking, well, she doesn't know my history or anything like that, but it was a really quick, process. So keep doing what you're doing. I think the reach out into the community is needed a lot more. But apart from that, brilliant service. Thank you.
Thank you. And I think just want to say in relation to the pharmacy experience, the other thing that will be different this year is we will have more independent prescribers in community pharmacy. And there's 3 of the Pathfinder sites are in Portsmouth. So actually more of our pharmacists will be able to prescribe in the community pharmacy, do the repeat prescription and then drive the care plan. So I think that's going to be a big change as well.
Where are these people coming from?
The prescribers,
Yeah.
So these are existing community pharmacists. Yeah, apologies. And I think our pharmacists are really skilled. They're skilled clinically, they understand medicine. Often it's been difficult for them to prescribe unless it's through a particular patient group directive.
Okay.
The aim of this programme is to extend the base so they can do your long-term conditions, your oral contraception, your hypertension. So then people are coming for the complete service, they're not being referred back. So that will change things as well over the next 12 to 18 months.
Cool. Gillian.
Yes, there was a couple of things I wanted to say. One thing I just wanted to echo what a couple of colleagues have said about the digital inclusion. And I think it's not just the digitally able, I think it's also basic access to Wi-Fi and the inability to, I think you're always going to have a cohort that need to be able to access face-to-face services. I'll just say that. I just wanted to come back to the dentistry because I read a very interest about it's very exciting to get that. But is it extended into the Havant or outside Portsmouth areas? Thank you.
Yeah, so mobile dental unit in the first instance is across Hampshire and the Isle of Wight. What we've also done alongside that is we've entered into and completed some very ambitious procurements. So covering Portsmouth, Havant, that side of the county, we've got an additional, I think, 60,000 UDAs. We've done a similar programme on the Isle of Wight, and we're just completing the programme in the Southampton area. So I think what we've been able to do, and I think the dental school will help, is change the perception of Hampshire and the Isle of Wight in terms of dentistry. I think historically we've been seen as a dental desert, but we're slowly changing that now in terms of creating more provision, supporting the dentists we have. And I do think the dental school will be a game changer because it means actually we're encouraging people to study here and stay here and work. So lots to be positive about, but still a lot to do in the interim in terms of extending access.
Yeah, obviously just say if it's not your sort of area, but is there much work done around the lack of routine prescription drugs being available when they're in effect the demand is there? So without sort of going into individual cases, I know that quite often people have routine things where they have to take drugs all the way through the rest of their lives, and there seems to be quite a high incidence of those drugs not being available or really being rationed, and patients having to go to different chemists around certainly the city. That must cost in effect the NHS quite a lot of money, and presumably there are contracts with drug companies. Is there anything sort of around that you can explain, please?
So it is the global economic circumstances is driving up price of medicine. Political choices such as Brexit means that we pay more for medicine now. There's also something which you may be aware of, that the previous government imposed a levy called VPAS, which is a value price access scheme, which means that actually companies have to pay more of a levy. And I think that's led to certain companies not providing medicines in the UK, shrinking their provision and their supply. So it is an issue. at any point in time, if there is notification of a shortage or there is a shortage, we would enact a sort of a business continuity plan. We would look to make sure we could provide the medicine, albeit from another provider or in a different way. Often that will cost us more money because we're paying a premium. The government are sort of looking to sort that. They're lobbying with the specialist pharma companies and the generic pharma companies to address it. It is an issue. It's also an issue for community pharmacy because a lot of their income is on dispensing of medicine, and in any one day they might be dealing with a price change for them from £6.80 a pack. At the end of the day it could be £8 a pack. If you're doing that at volume, that's a significant impact on bottom line. So I think the government is seeking to address it, but it is a reality at the moment, and it often leads to us having to put into contingencies which are far more expensive and probably less sustainable in the future as well.
So the follow-up to that is that was really helpful. So do you know of a sort of like timescale of where it might get addressed through what looks like might happen, or are you just saying what you think they're doing, if you see what I'm saying?
Yeah, I think the only assurance I can give the committee that as those things arise, we absolutely enact business continuity plans. We work with NHS England, we work with suppliers, we put alternative formularies in place so medicine is provided. In terms of the national position, can't comment, but I understand the Secretary of State has met with all the sectors and they are working towards perhaps a variation of the existing deal which will be more amenable to the companies.
And you might have already said this actually, so I think you have a new answer, but I'm just sort of interested. So does it detrimentally, apart from sort of in terms of, you know, customer experience, if you want to use that expression, and causing, you know, queues and things like that, does it financially cause problems to the pharmacies if people have to keep going back because a routine drug isn't available when it's not prescribed?
I think when there's no cheaper medicine available or no alternative stock, people are buying at a premium, so that creates a cost pressure. People will then not go back to that pharmacy if the medicine isn't available, so it impacts on the business. And in fairness to our pharmacists, in spite of that, they do all they can to make sure medicine's available, and a lot of them are operating at a loss to continue to provide a service. So I think alongside the medicine supply bit, there does need to be reform of the national community pharmacy contract to make it more viable for the contractor. So I think you're right to say there are issues of sustainability, and hopefully the new contract reform will address that.
And when we lose a pharmacy, is there any research done about the factors towards that? So I'm wondering whether this, over a number of years, has been a factor for some of the pharmacies, because I've lost some in my ward.
I think there's national evidence to support that. I think we would always, you know, in a point of a time where a pharmacy closes or changes hands, we would naturally be involved in that process. So we'd have an understanding of the reasons why. We'd be able to do a root cause analysis in terms of the driver and sort of try and manage that differently. The big challenge for us and the local authority is we operate a pharmacy needs assessment. At the moment, the way that's set, and it's no one's fault, is quite rigid in terms of how decisions are made. We're really keen that actually future P&As include the fact that pharmacy is a key access point as evidenced by the data, and I think we need P&As to consider that in a more rounded way. A key consideration is not just the provision of medicine, but how much additional access that pharmacy provides in the community. And I know in Portsmouth, in some of our more deprived communities, those pharmacies are key. So hopefully we can change the way we plan together as well. I know public health teams are looking at that.
I wasn't going to do another follow-up, but this last one. So is that something that you've got control over, or is that, as a body, or is that something that, in effect, you need the government to change their rules?
I think it's national in terms of standardisation of P&As, but I do think it's probably a debate we need to have across health and social care. What can we do to sort of adapt or change the considerations? Access is more important now in pharmacy than it was 2 years ago because of Pharmacy First. So if we're only making decisions based on 4 criteria and we're missing the point, we're going to continue to lose pharmacies or not have enough.
Any other questions? Yeah, Charlene.
Yeah, sorry, I was just thinking then as you was talking, I think one of the challenges you could face with pharmacies, and it's a question that actually I had myself, was going back to the oral contraception. There was only one member of staff that was allowed to administer. Otherwise, I would have had to have travelled elsewhere. Now, the problem with that is, for me, is my pharmacy luckily is attached to my doctor's surgery. Will other pharmacies have that information from patients, having that access to that? And obviously there's a team of people working in the pharmacy. Will more people be able to administer medication rather than just wait for the one senior person to do that? Thank you.
So I think we are working towards our shared care record. So pharmacists would see the same version of the care record as the GP, and that's being worked through. With independent prescribing, what that will mean is that the pharmacist will be freed up to do the consultation, but at the same time, the technician, the counter assistant are trained so they can pick up the other tasks. So you may see more pharmacists in the pharmacy, or you might see more of that pharmacy time directed towards frontline care. So it's just making sure that across the team, there's a range of interventions that can be picked up. Pharmacy technicians are really valuable in that they can prepare medicine, they can have a conversation. And in some pharmacies, counter assistants are doing a lot of the initial consultation and then signposting. There's certainly more we can do in that regard.
I think you already said it, but have you got the figures of what age breakdowns it is that are using pharmacy first? I think you said something about high.
I can inquire. I can inquire on that. Yeah.
Cool. Thank you, Judith.
I think there was a step change for much of the population when the major pharmacies or certain pharmacies took to doing COVID injections and indeed flu injections and other things, because you can see when you go and get that done in a pharmacist that they're linked up to a computer that is presumably feeding into our national GP records, I assume, but it all looks as if that's what's happening. And I think that has improved the public's perception of what pharmacists can do a really enormous amount, and that I hope that continues.
Any other comments?
Does it feed it? The information about injections, does that inoculations, that does feed straight through? Well, that's showing people that this can happen and that the electronic patient record is a reality. I think it's really important. Thank you.
Any other questions? No? Thank you.
Thank you.
Is that a cover for Siobhan, do you think? No. Not going to make it. Oh, right, okay. Okay, so agenda item 4, which we jumped ahead of, was questions directed to Siobhan. So she thought it was an online meeting, so she is watching. So if anyone has any questions, then we can email them to her. So just let us know.
If she's watching and listening, presumably she can then phone in or email you with the answers now straight away. Potentially, I guess.
Yeah.
She set the time.
Yeah.
Circumventing the.
Need like a chat.
Yes. Yeah, she thought it was an online meeting. Well, we can circumvent that if she's there doing it. Okay.
I think what we'll do is we'll collate the questions. We can email Siobhan and then she can just email us back all the answers, all copied into everybody. So we all know, I think, otherwise we could be sat here all afternoon going backwards and forwards. So if you do have any questions, then you can either jot them down now and pass them over, or just email by, I don't know, the end of the week, something like that. Is that all right? Perfect. Thanks, Siobhan. So, agenda item 6, we've got Portsmouth. Oh, well, yo.
I had a question about this report.
For Siobhan, yeah. So if you jot it down, we're going to email her.
I think it's if this meeting particularly is being published, it's important that
Okay.
people hear.
Yeah, okay, yeah. Yeah, if you want to discuss the question there, that's absolutely fine.
The question is about page 17, the Health Watch Portsmouth Outcomes, 2024 to 5. People who know me well will know that I've been down this list, and nearly all of them make me say these are not outcomes. Outcomes are specifically what is an outcome for patients and for the population, and these are all results. They're things that have been done and are improved. So non-digital format health information, records now flagged. They're all great things, but they're not outcomes for patients. If you look down the list here, every single one, you can say, so what, in terms of what the improvements are for patients. I guess some of them, for example, dementia carer concerns, encouraged by HWP to have their say, the outcome would be carers get more and better support. And I suppose in that situation also patients get have a better life. GP practices sharing information across the city, that is aimed only, it's not because they like talking to each other, it's aimed at actually improving outcomes for patients so that the patients wait less time, they're less held up by people not having talked to each other, and they actually have better lives. I just make the comment that I would like to see reports that go right down to what differences that make to populations and individuals, and answers my so what question that I always ask. That's all. I can imagine that her answer will be, yes, we'll look at that, and I'm quite happy with that. But really, these are actions, these are results in terms of the means to getting to the outcomes.
Could I propose?
Thank you.
So that can happen. Can I propose that this report gets brought to the next meeting with Siobhan, and then we can properly
Yeah, definitely.
as well.
Yeah,
not instead of that.
yeah, I mean, there's no harm in sending the questions, and she's actually got the answers to come back to the next meeting. I'm more than happy with that. Yeah.
The only thing I don't know is, does Health Watch still exist then?
I don't mind.
Does, yeah.
But I think Health Watch do a great job, it's fine, but the report in itself
There they
doesn't go
stopped.
far enough.
The only thing that I've just suddenly thought of is that I think the government are stopping Health Watch, aren't they? So I don't know if they'll still be going.
relevant. Let's just cover every basis. Okay, so fire any questions over towards us in a group, kind of, so that we're all transparent. We can get Siobhan to have those questions. She can either email us all back, and if possible, and if it's still relevant, we can bring this report to the next meeting as well. How's everyone happy with that?
Yes. Thank you.
Yep, just a quick one about the new digital initiatives. I wonder how the use of AI and assistants like Dora are being evaluated for effectiveness, improving patient care.
Any more? Oh,
Well,
Judith?
the other thing to note is the report on Pharmacy First. It's 52% of respondents said they'd not previously heard of Pharmacy First. Going back to our previous discussion, there is still work to be done.
Yeah.
But thank you for that's an interesting piece of research.
Matt?
Yeah, just a comment on the Pharmacy Festival. I think it's a really great initiative.
Yeah.
I think anything that takes pressure off of local GPs is good for patients.
Yeah.
And we were talking about people believing in their GPs again. I think this is something that can free up really important appointments and let the pharmaceuticals, the pharmacy side of things look after people and you really use their skill sets
Yeah.
to help their communities.
Yeah, definitely. I mean, my experience of Pharmacy First is personally, and for my daughter, they've been absolutely fantastic. I think it's, you know, it brings that community element that actually there's a person straight there. You don't have to go for a receptionist. Actually, there's a medical professional straight there. So it is really appealing and doing well. So, Susie?
Following on from a couple of things that Matt said, I think I've seen in Portsmouth a kind of click and collect kind of thing, pharmacy thing, where you can, a bit like those lockers. Are there plans to do that more? I'm thinking particularly with routine medication. And I know that one of the pharmacies on Albert Road has robots collecting. It's really great to watch, but they have robots collecting all the prescriptions. The next step for me would be that they were then put into a locker. So in actual fact, you could end up getting 24/7 pharmacy. I just wondered what the plans were in Portsmouth. I might have dreamt it, but I think I've seen one somewhere. Maybe it's just an inspired idea that I need to take credit for. No, but you can see that, can't you?
Yeah.
I mean, stuff around flexibility and access to what is obviously already had a professional input.
Yeah. Matt, did you have a...
Well, I just wanted to say that I think it's really good to hear that, you know, it's not just going to be the lead pharmacist that can help people as well. It's the whole team really chipping in, so I think that's really good to hear.
Yeah, definitely. Any other questions from the floor? Is everyone happy to move on? Agenda item 6 then, Portsmouth Hospitals University Trust update. Welcome.
Thank you, Chair. So Simon Barson, Chief Operating Officer at PHU.
Hi, Juliet Pearce, Director of Nursing, PHU.
So in terms of the paper, I'm assuming it's all been read, so I think where we are currently compared to now, so we've had a bit more of a challenging August in terms of urgent care provision. So we saw a drop in 4-hour performance in August to around 92% from the 95% delivered in July. We continue to see a improvement and a really good performance levels against ambulance holds, so that has remained around 13 minutes. As it shows in the paper for context, a significant change compared to the same time last year. And for note for the committee, for July we were 3rd ranked nationally for ambulance handling performance, and we were the best for South Central. So compared to everywhere else in their patch, a real positive there. In terms of other areas of urgent care to note, we were in urgent care tiering with NHS England at Tier 1, and that was for the whole of Hampshire Isle of Wight, so all the acutes in the same position. Through the latest updates, we're now moving to Tier 2, which is a positive for us alongside Hampshire Hospitals, with Southampton being in Tier 1. So it means that the process we go through is a lot less intense, and the meetings aren't as often with NHS England national team. They're more regional meetings. So it doesn't take away the focus, but it's a different angle and different areas they look at. It is worth noting that through July and into August, our non-criteria to reside numbers, so there are patients that are in the old world medically fit, has continued to increase. And we are now around 250 in the organisation in August. For context, that is more like winter levels of demand for those kind of bed areas. So for last year, for example, in January, we were around the 250 to 300 mark. In August, we've gone up, as you can see in the tables, it has been a increase since January that hasn't really come down, predominantly driven by volume-wise P1 patients, so patients who are trying to get either home or with increased package of care are having a marked increase there, as well as the P2 and P3, but particular challenges around the P1 at the moment, and I think that's been felt across the whole of Hampshire as well. There is work going on with our Hampshire Isle of Wight Foundation Trust colleagues on what we can do with that, as well as the council, because a predominant number of P1 is Hampshire County Council driven. So it is worth noting that is a ongoing concern which is following us into September, alongside increases in demand as well at the front door. So we are seeing, despite we've already seen a 9% increase in type 1 attendance, so that's the emergency department themselves, that has continued in September and is causing us a bit of a concern. Predominantly driven by walk-in demand, so not necessarily from the ambulance service themselves. It is people making their own way to the hospital to be seen in our emergency department. Our work continues with our primary care GP alliance. We've got GPs on site who are running out of a building next to the emergency department, and that is really helping that flow of patients from the walk-in area into that unit, because we do know that around 40% of our attendances that are walk-in attendances are primary care in nature and don't necessarily require an emergency department level response. So we are managed to sift off every day around 60 to 80 patients to that unit, which is really positive, and that runs 7 days a week. So we're going to keep going with that and obviously look at how we can enhance some of the pathways that go in there. In terms of the elective position for the organisation, those that people that are receiving elective care, we continue to work towards our 52-week position of 1% of the waiting list over 52 weeks by March. We're currently around 3.8, so we're on plan to reach that position. There are a number of pressure points within that cohort of patients, and that is predominantly driven by head and neck patients. So ENT as a speciality is challenged both from a routine perspective but also a cancer perspective. And alongside that is gynae and bariatrics. So they're the three big challenged departments in terms of focus on those long waiting patients to bring that waiting list down, which obviously continues through the year, acknowledging pressures in winter make that a lot harder in terms of bed capacity within the organisation. But there are some recoverabilities in there we're looking at. A particular aim is the front part of the pathway. It's taken us too long to get people into clinic appointments, which then means the actual surgical end doesn't have enough time to be done. So when you're running a outpatient wait of 25 weeks, you aren't giving much time for anything else to be done, and that wait needs to be brought down, and that wait isn't equally impacted by winter itself because these are clinic appointments, not operations. So there's a big focus there, particularly in head and neck, around converting clinic appointments from follow-ups to news to try and really get ahead of that hump of patients we have in the middle that we currently are struggling to break down. So that starts in September with a big increase in appointments in that speciality in particular, and then we'll monitor that over time and we'll start rolling that out across some of the other specialities as well to try and really focus that front end of the pathway, which is causing us challenges. So I'll pause there, but happy for obviously Juliet and I to take any questions.
Over to the floor. Mark.
Yeah, thanks. I was lucky enough to have a quick look around the emergency department when it was first opened through the invites from your colleagues, so thanks for that. So now that that's happened, is that impacting on the 4-hour standard? And I know it does say here about the increase in demand and delays about patients' discharge, but actually it seems a bit sort of, on the face of it, odd that the 4-hour is getting better and nearly hitting the standard, but the 12-hour is not. So are you able to say a bit more about that?
Yeah, sure.
And
So
what the cause of that is? Is it to do with the setup, or is it other parts of the NHS or individual problems that are getting larger in society?
So if we take 4 hours as the starting point, so you have to remember that from an emergency department perspective, roughly only about 28% of patients get admitted. So the rest of the cohort that attend the emergency department are emergency department patients to manage. And to be fair to them, in the new space they have, which is 3 times the size of the old emergency department, it does give them the space to see these patients in a more efficient and effective way. So if you look at our performance split by what you'd call admitted patient performance and non-admitted, our non-admitted performance usually ranges between 75 to 85% performance against a 4-hour clock, which accounts for the largest cohort of patients on a 4-hour clock. So you'd see a denominator increase for them. Our admitted performance against 4 hours roughly sits around 20%, which is where the impact is on 12-hour performance, because those patients are waiting for beds. And what you'll see if you break our 12-hour performance down, only 4% of those patients are not admitted, and they are currently what we classify as our overnight hangovers. So patients that will attend the emergency department at, say, 9 o'clock at night, where the SDECs have all closed, there's no UTCs available locally. Those patients will usually sit in the emergency department and wait till the morning for somebody to do something with them or for them, and that is where that cohort comes in. What we're doing as an initiative from October is we're taking the GP service we have, we've got our own emergency care centre service, and we are kind of putting them together as a single service. And that service will also, as part of the process, have bookable appointments. So what you'll have is if you attend the emergency department and those 2 units have closed, so after 10 o'clock at night, but the team and ED following triage believe you are appropriate to go to those areas, they will send you away with either a bookable appointment the next day or a GP callback the next day. So the aim is for that to go live in October, We think that will impact, and clearly it varies by day, but we expect that to be around 20 patients each night that come in who could be sent somewhere if firstly the emergency department team have confidence they'd be picked up, which is always a bit of that clinical worry around who will be there for them. And then also for us, the bigger challenge, which I know Juliet and the team nursing-wise working on, is persuading the patient to go. So we do struggle at QA site. Once they're on QA site, it might sound strange, but they will happily wait 12 hours in the emergency department, knowing they'll be seen by a clinician at some point in that journey, then be sent away to come back. So we've done quite a bit of work with our local NHS England team and our regional team. So there's a very good model at Maidstone, Tunbridge Wells, who run this. And I've run it, so we're at the baby end, they're probably the grown-up end. They've run it for 5 years. And they now run it from their end. Any walk-ins that come in, they can offer them appointments throughout the entire day. So if you came in at 2 o'clock now, they may say to you, well, actually, go away, have a coffee, have your lunch, come back at 2 for an appointment. So we've been linking with their clinical leader around how do we do this? Is our pathways right? Is the process right? And his point is, it's all right. The hardest bit you have to break through is the patient willing to go home or, go somewhere to return. And that took them a bit on their journey to get through. But once you get in the rhythm of doing it, and a lot of people do usually frequently attend the emergency department, they get into the rhythm themselves of, at least I know that I will get a call back or I will get an appointment for the next morning. So that is a piece of work there. So for 4 hours, ED own majority of that performance metric. So the ED itself has absolutely helped them with their flow and process of patients at a quicker pace. The Alliance input from January has absolutely helped as well, because they're turning away 60 patients at the first point of contact. So if you come in and they triage you within an hour, they will send you away to the GP, which is the appropriate pathway. You will have achieved the 4-hour clock from an ED perspective. 12 hours is predominantly bed waiting patient provision, which is where the NCTR comes in terms of the pressure point in the beds behind, because the predominant volume of the NCTR patients, the medically fit patients, sit in the medical bed base or the geriatric bed base, and they are part of the biggest take in the acute, which is the medical take. So if you haven't got the beds behind to move into, that's where you get the bottleneck of patients who then remain in majors in ED, so that the new ED has them in there, but it does put pressure on there and their ability to manage those patients, because they are no longer their patients, they are a acute medical patient or a cardiology patient. So it does stifle that 12-hour end, absolutely.
Yeah, thanks for that. It's really exciting, and thanks for the comprehensive answer.
Thank you, Chair. Reducing ambulance handover times from over an hour to just under 14 minutes is a real achievement. Could you tell us a little bit more about how this has been achieved?
So I think, we started the journey when we moved into the ED, and I think the process for the organisation was very much, this is an organisational problem, not an emergency department problem. We've worked heavily alongside our South Central Ambulance Service colleagues around how do we ensure we keep the flow going. I think there was a lot of work done very much around the pressures in the organisation are our pressures, and we all do get very siloed into our problem is the patient in front of us. We've spent a lot of time on quite a journey of focusing more on the patient who's at home, who the ambulance cannot get to, who may well be having a heart attack, a stroke, who, you think an hour and a half wait to get for a delay at an ambulance at the front door will be hours and hours delay within the community. So we've done a real drive there. And what we've really pushed is that risk threshold and appetite within the organisation itself. So that has meant at times pushing up in high pressure into areas like corridors, for example, which is something that happens at Southampton as well. It's how do you keep them going. But what it's also allowed us to do, and our ambulances to do, is to genuinely have that focus on, I will only send to the acute what really needs to go to the acute. Whereas when you're swamped with volumes of calls because you can't get your ambulances to them, you find that a patient at home who's been on the floor for 6 hours, no matter what we do, the pathway for that patient is to send them to hospital, because you have to do multiple tests at that point that cannot be done on an ambulance. So we have reduced the number of what you call inappropriate attendances to the ED from the ambulance service, which is why we've actually not seen these dramatic spikes in numbers. But it has meant the organisation itself has taken more of a risk focus, not just in the emergency department itself, but across all the specialities behind that emergency department, both operationally and clinically. So it has not been simple, but I think it has shown what can be done when an entire organisation buys into a premise that the biggest risk is the community risk, not necessarily the acute risk. You know, if you become unwell on a ward and you're not in the most perfect space on that ward, you are still on a ward with a consultant team, a senior nursing team to support you. If that happens at home, it could be you on your own or you with a relative. The risks are not parable. So we've spent a lot of time doing that. And we're still, it's a journey we're still on. So we still have tricky days where that doesn't necessarily work. But responsiveness there is good. And also I'd say for my colleagues at the ambulance service, where we do have pressure points and challenges on days, they're equally responsive to those challenges, because in built-up pressure points, people can sometimes be not as civil as they need to be from both sides of the organisations. But what we found is when that does happen, our ambulance colleagues are very responsive to sending what they call their base commanders up to site, because if the nurses are struggling with the volume, you need a bit more of a calming head from an ambulance side saying, I get what you're trying to do, but take the context of what's around you before you start saying, where am I putting my patient conversation? So yeah, a big journey. But I don't know, Juliet, if you want to add to that at all.
Yeah, I mean, I think it is a really good partnership working with SCAS. And as Simon said, I think the way that we went into this is sort of weekly partnership conversations as we were moving along the journey. Really good auditing from SCAS, because Simon's right, we're absolutely committed to the fact that outcomes for the most vulnerable patients, our CAT 1s and 2s, are the priority, and those are patients that are having a heart attack or a stroke and they need an ambulance with them then and there. But conversely as well, if we are releasing ambulances to go out to the CAT 3 calls, they are patients that could be seen and treated in the community. Our ambulance colleagues never had the ability to do that before. So some elderly people that fall at home with a bit of time and support from the ambulance team and looking for other sort of ability to signpost to other areas of support won't need to come into hospital at all. But Simon's right, absolutely. If they've waited 6 hours for the ambulance to come, they're coming into hospital. So that ability to get ambulances there quickly should allow them to convey less of the category 3 patients as well.
I think I'm going to ask the $1 million question. It's the challenge. Just this week, I was shredding my mum's medical record. She passed away a couple of years ago. And apart from being a bit of a journey of PTSD, it raised some questions which I'm going to focus on. And so it's not the personal thing I want to say, but it's my experience from it. And I guess the $1 million question is, how can we become more patient-centred? So I think my mum engaged with about 7 different departments at the hospital. And she had complex needs. But there's quite a few things that, for me, were really crucial in the relationship between her physical health and her mental health. First of all, without me, I don't know whether she would have been able to manage it, because of the complexity of the communication. And the second thing is duplication of, I think I had 2 letters for every single appointment that she had. But more importantly, it was and interestingly, you mentioning ENT, because that was one of the departments she was under. It was, and I can't speak highly enough of the quality of the care that she got once she got in the system. But it was forever, for me as a family member, but also for her, is not understanding how it fitted together and the amount of people that were involved. And then also the discharge process into the other care that you get when you're discharged, and the re-enablement team. I think there were about 40 people who were involved in that. The whole thing was so exhausting and almost incomprehensible, and to either my mum or to me. And I'm in the system. I kind of knew about it. So I guess I don't have a direct question, but is that something that there is a sense of that between the different departments within the hospital around health outcomes because of the complexity of the situation?
Yeah, so thank you. And I think absolutely there is a recognition that whatever the outcomes of clinical effectiveness and outcomes of care for our patients are, we don't always get the patient experience part of it right, and that we haven't as yet, always found a way to be really, to really co-design our care with our patients. We have a new Chief Nursing Officer who started, who is very keen to look at the way that we actually actively seek and use patient experience and feedback to improve our services, which I think will be really helpful. We do a number of things already, so we monitor our complaints and our concerns, and we get real-time feedback, and we look at inpatient surveys, but I'm not sure that we've yet used that to really drive changes in the way that we deliver care. So that is absolutely something that we're looking to do with a new patient experience strategy. We're doing quite a lot of work in the discharge space at the moment with partners in the system. They are really complicated pathways, and obviously we have a Portsmouth area and we have a Hampshire area, and they used to do two completely different things. We now have an integrated TOC, a transfer of care hub, and there is a big bit of work going, and it will take time to do, to standardise the processes. That will make it easier, I think, for our patients, their families, but also for our care staff to be able to navigate that discharge process, because I think it is probably one of the most complex systems I've worked in, and the routes to kind of making it easier for everybody is to standardise that. So I think the integrated transfer of care hub is a really important step, but what we need to do now is make sure that all of those processes are standardised.
Thank you. I suppose, apart from the personal experience, actually, I used to increasingly feel frustrated about the inefficiencies in terms of finances and things, because the duplication of so much, and the duplication of information. When you get passed to someone else within the hospital, you get passed on to someone. I know there's record transfer, but then you'd start from scratch with everything, and it just felt to me that there was there must be a magic matrix where that communication flow is efficient, both in terms of care but also in terms of finances as well. Thank you. I know it was a complex question, but
would it be all right if I just came back on the digital piece, so, and the communication transfer of information? We are still largely working in two systems, digital and paper, and I don't think that helps us. Hampshire and Isle of Wight are moving towards an integrated patient record, so that all hospitals in the patch will be using the same digital system. Now that is at the moment in the procurement stage, so I think they've done the work around saying this is what the system would need to look like. They're now into the procurement stage, and then it's going to be a long, probably a 2-year period to get that system completely up and running. While we are all working together on that system, we have the opportunity to do the streamlining. So that real opportunity to look at everything we record and all of the information we ask for, and make sure that it flows right the way through that electronic patient record, which I think will reduce the amount of times that people are asked for the same information.
Yeah, I just want to follow up on that actually. I think as counsellors, we get into this to share our stories and to want to make a change. I mentioned about my 3 conditions. My son actually has one of them, which is Marfan syndrome, and he was tested at Southampton. We were always told, because the condition could affect the aorta, if he had any chest pains, call an ambulance. I have to say, a couple of weeks ago we did. Because Portsmouth can't access his medical notes, we opted for him to go straight to Southampton, which roadworks, it was over an hour. They were absolutely amazing, but it's just following on really about the integrated systems and if that does impact the waiting times, because I think last year he had a fracture which he needed to have it operated on, and he was booked for quite a late operation. He was fasting, I think, 12 hours, and then they said, sorry, we can't do it tonight because we can't get his medical notes from Southampton. So there is a real need for that. Just going back quickly to the ambulance service, I think the one group of people we haven't said thank you to, and I'm sure you all are thankful, is the first responders. Again, when I had to call the ambulance for my son, there was a long wait, I think, Basingstoke. So the first responders came in, I think after about half an hour, we had about 5 people in the room. So, you know, they are trying their best, but the first responders are critical, especially in rural settings where a patient can't get to the hospital. So just want to say thank you as well. I'm #1 customer of the NHS, so thank you for everything that you do.
I wanted to pick up a little bit on what Councillor Horton said about discharge. I've had the privilege of looking after somebody in their last 4 or 5 years of life, and I must say the lack of coordination and the lack of plan for her was really a major issue in what she knew in the last few years of her life, and we all did, and was not dealt with. Just a minor thing, we were talking about it earlier. Please make sure your handover notes always have whether somebody's got an electrically charged pacemaker or an electrically charged pair of hearing aids. Because every single time I went in to see this person in a new setting, nobody knew that we'd also packed in the plastic bag the chargers for both of those things. Why the headquarters of the people who fitted her pacemaker didn't call up and say, is she all right, has she died, I do not know. But those are so crucial, particularly the hearing aids, because she literally couldn't make herself understood and got incredibly cross and frustrated and got a reputation for being an awkward patient. Put the charged up hearing aids in and she was sweet as pie. But I had that experience 4 times in the period of about 6 or 8 weeks when there were transfers between 4 settings. That is not good enough nowadays, and that must be on those notes, those patient notes. Note, plug in, charge up. But the most important thing I wanted to say was about the discharge arrangements. Again, I don't think this is atypical, but a friend of mine recently had a under general anaesthetic operation on something needed to be done in her stomach. She didn't particularly want to stay over at night, so she accepted the offer of going home. She had a husband who could care for her, ideal, perfect, you want that. But the absolute promise was made that a district nurse or somebody who could look at the drain and the bandages she had, because there was quite a lot of surgical equipment left on her body, would come and would contact them the following year. Not a sign of it. Even when ringing up, people at the hospital didn't seem to know about it. You have to get that, I know you know this, you have to get that promise of post-operative care that would have been done in the hospital, probably should be done at home, but somebody's got to come. And she certainly, who may face another operation of a similar sort, so I'll never say I'll go home until I've had everything done in the future. Well, that's probably 2 days in hospital. Somehow there's just absolutely a few things. I know you know this, but it's so crucial. There's a bad experience once and people don't go back through the same path themselves. They make choices about other pathways. And she won't agree to discharge till she's had all the drains and everything else removed in the future.
Yeah, go for it.
Yeah, so thank you, and sorry to hear that's never a good story, is it? And I think it is would have been useful to have primary care here, because the community services, obviously, we liaise with community services. We don't run the community services, so every individual case would have to be looked at, but it may well be that the hospital has organised and done that, and then for some reason the district nursing services which are running out of primary care aren't working. That doesn't make it any better for the patient, but the complexity around the amount of people that are involved in a safe discharge does mean that there are opportunities for things to go wrong, and we need to keep learning from them. I think that it's really important when we are looking at the ability to discharge patients from hospital sooner. That isn't just because of what happens to the patients who can't access care, because if there are patients in the hospital who don't need to be there, the issue that we have is that we have patients waiting more than 12 hours in an emergency department, which is not anything that we would want for any of our patients. But also because outcomes are poorer for patients who stay in hospital. They are very risky places actually, if you are not requiring that level of care, both for healthcare, infections, for falls. They are terrible environments for people who have dementia or cognition issues. And so when we have patients who do need to be cared for somewhere else, either in their own home with care or in a rehabilitation bed, we're not just trying to do that because it's the right thing to do for patients accessing care. We're trying to do it because it's the right thing to do for patients as well, in terms of their outcomes, which are considerably improved if they're discharged to an appropriate place as soon as they're ready to go.
I'm not trying to knock you. I think the figures you've given us are really inspirational. I have been on a hospital board and I know how very, very difficult it is. And I just think it's very good to see this, despite the difficulties with the lack of money and raising costs through the minimum wage and all those sort of things. I'm amazed and I'm very grateful for what you've actually done.
I've got a question again around the discharge. And you've stated that approximately 1/3 of these delays were due to lack of out-of-hospital capacity. I just wondered roughly what are the other 2/3?
Should I take that? Probably about another third is what we call interface processes between the hospital and other providers. That can be funding decisions being made. We've talked here before about that. It can be around Care Act assessments having to be done by adult social care. So not all of it is true capacity. There are delays in other parts of the process that it takes to get that patient to that place, and financial decisions around who's going to fund care is one of those issues. And then there is a smaller proportion, but where it's hospital processes, so things that we have complete control over. We're doing our own improvement methodology this year for the year on improving discharge processes. There are lots of things that we can improve. We're focusing very much particularly on we call our board and our ward round standard processes, and that is about the understanding the patient's needs, communicating well with the family, planning in advance, escalating delays. So we're taking ownership for the part that we can control, but the other parts we are doing a big bit of system improvement work with. And I don't know, Simon, if you want to talk about the PSEH improvement plan.
Yeah, so we've got a programme of work across all our partner bodies in terms of how we're going to manage what they call discharge ready dates. So we're a bit of an outlier in terms of our performance against that area. And so we've really brought together Hampshire Isle of Wight Foundation Trust, Portsmouth City Council and Hampshire County Council around how do we maximise our pathways that we have, where we know we've got probably more patients in the pathway than we have the money for. But we also have other pathways where we don't have the patients, but we're putting patients in them anyway because we need to get them out of the hospital, but it's maybe not the right pathway for them. And trying to do the bit, as James described before, around when trying to get rid of the rigidity of these pathways to try and make them a bit more flexible in terms of, we know our biggest pressure point and volume is P1 patients, and yet we don't have the capacity money-wise or staff-wise to do that. We know we are an outlier to the amount of P2 beds we have, so rehab beds. So the conversation with Hampshire right now is how do you move from a P2 capacity to a P1 capacity, which is where it's needed to focus on there. And I think something that Juliet's described around funding on pathways. So you can have multiple pathways that are pretty much, in layman's terms, the same thing, but a proportion are funded by the ICB and a proportion are funded by Hampshire County Council. And that alone, I think, averages around a 10 to 12 day delay in decision making around who's going to pay for that care. Even though the outcome will be someone's going to pay for that care, the pot is the pot. So to be fair to colleagues at the council and at the ICB, again this month they are simply, which sounds really simple probably to the committee, putting the pots together and the decision making together so it's one access point. The pot is still the pot, however, but the aim there is for those particularly long waited patients, you should drop their pathways by 10 to 15 days. And as Juliet said, these are patients that are fit and ready to go. And we absolutely know that, particularly as we move more into the winter months, what the focus is now on this is because in winter, from the acute perspective, in terms of, as we said around, it's not great environment for dementia patients. There's a high risk of falls. Through winter, you will add in their flu, you'll add in their COVID, and you will add in their norovirus. And we know through last year, on norovirus outbreak, I think around 70% of the patients that got norovirus were medically fit. So we are causing risks and harms in that by not streamlining these processes, which is challenging in August, but absolutely the bleakest of winter in January, that would be even harder to do. And we are expecting, obviously, the standard spikes in these, infections. In particular, this year, COVID, there is expected to be a significant spike in COVID in January, which we didn't see last year. So I think the work is ongoing. I think we are trying to drive it as PHU, not only because it will help us, but it will help the total system. And I think we have probably got more buy-in this year than we probably ever had from system partners. So it does feel a lot more collegiate than it has been in terms of, well, you just need to get your patients out of the hospital conversation. We're now going to know about how do we do that as a system and not just as a siloed health care.
You're
So
already
thank you.
at capacity with your bed situation, and obviously it's getting colder, and we're going to have those incoming viruses. What are you going to do? What are you doing at the moment?
So at the moment, the aim from a system perspective is predominantly focused on the switch of P2 capacity to P1 capacity.
Okay.
So current estimations, I will say estimations in case it comes out later that it was more or less, is that should reduce the medically fit number about 40. Okay. So that is a ward and a bit of patients that will not be in the organisation that are in the organisation today. Mm-hmm. The other one, the CHC one, that equates to around 10. And I think our own internal process is around another 10. So we'll take an NCTR position of around 240 and hopefully get down to 180, okay, which in itself is 2 to 3 wards worth of patients being cleared for winter. We know there will be pressures in winter, there always are. I think we are fortunate with the new emergency department around the IP&C management because the whole of majors are side rooms. So you've suddenly got 39 side rooms in there to contain it. We did flu point of care testing. We've done that and COVID, so we can get a test on a patient, turn around an ED within 30 to 40 minutes. So you know, do they need to be isolated or do they not? And also for flu, particularly what type they are, because you can't put the two types together, because you can end up getting both. The one this year that we're trying to progress, which is going to be, I think, a big change, would be norovirus point of care testing. So there was a trial ran last year at Southampton through winter, which took what for us can be a 3 to 4 hour turnaround test into a 90-minute turnaround test, which again instantly allows you to make decisions at the front part of the pathway before the patient enters the bed behind. And what we found for our review of norovirus outbreak last year was a lot of that was firstly moving patients around, but also finding out too late in their pathway that they had norovirus and they were in a bay. And as people may know, that the spread of norovirus is significant and is exceptionally virile. So we are trying to put those in. So we then are using our bed base appropriately behind. And we're also working with our South Central Ambulance Service colleagues as well, because they are usually the ones that bring the patients in. And it's how can we manage that more effectively at the front door. So we're only conveying those that genuinely need to be admitted. And I think last year we had some healthy conversation with our colleagues around, firstly, you're bringing them in. If they have norovirus, how are you cleaning your ambulance afterwards? Because it's pretty virile, and how are you assuring yourself that you're not going away picking the next patient who hasn't got norovirus, bring them to us, and then within a week they've got norovirus. So there's a lot of work going on there, but the bed capacity particularly is around our own internal processes, which we know we have to do more on, and the system changing pathways and the footing those pathways to really try and drive down that medically fit position for winter.
And my second question, have we got the staff ready?
Yes, so we are in a really fortunate position at Portsmouth, actually, that we're over-recruited on registered nurses. Some people may have seen that there was a graduate guarantee scheme from NHS England around, which is the right thing to do. We've trained nurses over a 3-year, 4-year period that they have to have a job at the end of it, even if that financially is difficult, because it puts us in a place where we are over-recruited. And we have very few vacancies in healthcare support workers. So I think the work that's been done over the last 4 years, some of it around international recruitment, then starting to grow our own in terms of apprenticeships, has put us now in a really good position. So we don't really have a staffing challenge from a nursing point of view. There are, in terms of medical recruitment, and our medical director isn't here, we do have challenges with very specific groups and types of doctors, and that is some of the issue that will come through in the planned care demand. That is much harder necessarily to kind of fix, because you can't train someone that quickly. You are looking externally for somebody to come who is an expert in as an ENT surgeon. We have a very good recruitment programme for those groups of staff, but from a nursing point of view, we are in a very fortunate position.
That's excellent.
Can I just, sorry, and just add to that, I think, as you say, we've absolutely got pressure points from consultant perspective. I think the one area, again, plays back to the new emergency department, was this year we've been able to recruit an extra 4 to 5 ED consultants. Now, I'm not saying it was a build it and they will come scenario, but I think absolutely, you've become an emergency physician if you'd like, but there's an attraction to a new emergency department. Yeah. In fact, you know, with CT scanner in the building, with 3 X-ray machines, with an 8-bedded resus, that's the latest resus in the country. It has allowed us this year in particular to really focus on that ED consultant area, where we are in heavy competition, because down the road you've got a major trauma unit that has every speciality under the sun. gets all the major trauma, cardiothoracic. So you are bartering with those kind of people that are coming off the top from a deanery perspective to try and get the best. And I think the new emergency department has absolutely probably given us that edge at times, not all the time, over Southampton in terms of that attracting of consultants. And I think the other side of it is absolutely our ED team are very good at the sales pitch to new consultants, and they will cajole them, they will cuddle them, they will do whatever they can to get them to come to Portsmouth versus Southampton. So I think that has absolutely helped that front part of the pathway in terms of allowing us to look at our rotas through winter, where we can absolutely confident we can bolster those as senior decision makers. The key thing here is, particularly in winter, is the sooner you can get a consultant to the patient to make the right decision, the faster that pathway will move for the patient. If you've only got 2 consultants on a shift, when you should have 4, you will automatically start causing delays in that patient's decision-making process, because no matter how much we think they will, a junior doctor will not necessarily make a decision until they're spoken to the boss at times. So there's a piece of work there, but absolutely, we have got gaps in certain specialities, but I think ED-wise, with the change we made in the last year, we absolutely started seeing that come through in terms of appointments to consultant level.
Good. Charlene?
Yeah, I think it goes back to what I was saying earlier. Obviously, I want to keep mine and my son's care at Portsmouth. However, because of the systems, which I want to talk about now, because I feel if the systems were updated, we could have gone to Portsmouth. I'm a big policy lover. I love writing policies and trying to fix things. I'm 41. But I remember when I experienced that issue with Portsmouth not being able to access Southampton records, I remember wanting to write a policy on this. But someone of an older generation did say that this has been ongoing for years, that the government wouldn't fund the new systems. Has that been the case? Why in 2025 are the systems not in place already? And I think you said earlier, we have to wait another 2 years for it to be implemented. So, yeah, I just feel like we're so behind with the times, and I just feel you could do a lot more. It's normal folks on the ground who are experiencing these problems saying, why haven't we got updated systems? That's a huge problem, you know. So, anyway, I just wanted to share that.
I probably won't comment on the national issue and how we got to be in the position that we did. I don't all think it's been funding. I think we have tried to get a joined up digital system before, and that wasn't successful, and I wouldn't be the person to ask why that is. That's a national issue. I think that it does take, once you have the decision and the funding in place, it does take time, because we're talking about 4 acute providers who all at the moment do different things on different digital systems. So I think actually a 2-year implementation plan is probably not too long. It's what I would expect for that scale of change to happen, to get to the right point in the pathway, because you've got to agree all of the different pathways, of which there are hundreds, and everybody's using a different digital system at the moment. So I think it's I think that's a relatively good and swift outcome. What I would say is I think there's more that can be done and learned from other areas that do this well. So if you look at maternity records now, Badgernet is a digital system where patients have their own handheld records. You know, there is something about ownership of the notes. So, you know, is it something that, because you can do an access request to get records and hold records, they're your records. So while there are other systems needing to happen in the longer term that mean that shouldn't be an individual's responsibility, I think I would hold the bit that actually your notes are your notes, and you can, your children's notes, you can access them and have a copy of them.
Yeah, I really appreciate your response, and thank you so much. I can't access my records because what happens is a patient is meant to provide ID to the GP surgery, and then you get your records. All I can do at the moment is order repeat prescriptions and look at appointments. So there is a problem with the system with that. So it doesn't affect, you know, it's fine, I can pick up the phone or ask, but for some other people, they may not be able to access those records, which is why I asked. And, you know, it's not your fault, but I think in hindsight, this should have been done many years ago. You know, we are quite back behind everyone else, yeah. But thank you so much.
Judith?
This is a very short
Microphone.
This is a very short supplementary question to yours about staffing. Does that mean that compared with, say, 10 years ago, the hospital trust is using less agency staff than it was, particularly in nursing? Because that was a major problem of overspend and also a poorer service to people who I don't think really always got the best service they could from a rotating agency service. Have we reduced it? Is there a figure that one could cite?
Yeah, we have reduced agency spend in all staff year on year by quite an astronomical amount. And from a nursing point of view, I'm not aware that we've spent any agency in the last few months. We use temporary workforce, we use bank workforce. That is something that will always happen. That's to cover short-term sickness or maternity leave. But we don't use agency for nursing at all now.
Hooray, well done.
Any other question? I've just got a comment. My father's going through cancer care up at QA, and he was involved in an accident. And thankfully, he's, he's got all of his stuff in his head. But actually, the transfer of communication to his cancer care team from ED was actually fantastic, and that I think is credit to there is changing. Yes, we are, very behind on some systems. But I did 10 years in Southampton General Hospital, and yes, they're the leading way with their helipad and cancer care and immunotherapy. But actually, they've got their flaws as well. Every hospital, no hospital is perfect. But actually, what I experienced from going from an ambulance setting to stressing about the fact that he's got stage 4 bowel cancer, actually, they were spot on and already knew, and his CNS came down. So, that is credit. We are moving in the right direction. So yeah.
Thank you for sharing that. That's really nice to hear.
Kels, it's to do with diabetes actually, and just to say what an amazing support I've had. I think it was Portsmouth that ran a diabetes clinic for people newly diagnosed in Hampshire. Absolutely amazing. The communication was amazing from the nurse as well when I met people across Hampshire and Portsmouth, to discuss this new condition that we all have. So, it'd be good to get some more info out on diabetes within the community, because I think numbers are going up now. So more awareness on that. So, yeah.
Brilliant. Is there any more questions from the floor? No, I actually think this was a really great report. Obviously, it shows that there's still movement that needs to go, but we're going in the right direction. And I think the news on the agency staff is fantastic, because obviously that reduces cost as well. So, yeah, really great. Any other questions? No? Perfect. Thank you very much. Thank you. Right, did you get all that? Thank you, everybody. You're free to go.